So it's my pleasure to introduce Dr. Victor DeJesus, who's the lead chemist researcher in the newborn screening and molecular biology branch at the Centers of Disease Control and Prevention. He's going to give us a presentation on succinylacetone as a primary marker to detect tyrosinemia type 1 in newborns and its measurements by newborn screening programs. Dr. DeJesus.
Well, good afternoon, everybody. Oh, too loud. Okay, is this better now? Great. Hi, everybody. I want to thank SERGG for the kind invitation to come and talk to you all about the state of tyrosinemia type 1 screening in the U.S. But before I get started in that, my one and only disclosure is that I am a career permanent employee of the Centers for Disease Control and Prevention, and sometimes I'm a willing member of the federal bureaucracy that's been spoken of at this meeting already. So please don't hold that against me. Is that great? Another thing that I would like to offer as both an update to something that was mentioned earlier today, as well as yet another reason to hold this meeting in Puerto Rico, which is where I'm originally from. In some of the slides that were presented earlier, there was some information missing about Puerto Rico and the status of both SCID screening and CCHD screening. So I can say that for SCID screening, population-based screening started actually in August of 2015, thanks to a grant, an implementation grant that was awarded by APHL, or the Association of Public Health Laboratories, to the Puerto Rico Newborn Screening Program. I was just in contact with the director, Dr. Zulay Rivera, and she mentioned that they're coming up on the 1-year mark, at which point they're going to be publishing the results of their first-year experience. So indeed, SCID screening is going on for the over 30,000 births that occur in Puerto Rico. Now for CCHD screening, it's actually mandated by law in Puerto Rico, so it has begun and it is hospital-based. Now it's a little different from some of the other states in that the actual Department of Health administers CCHD screening. So there's very little communication between the newborn screening program and the folks in the Department of Health that administer the program. So she wasn't very sure about exactly how wide CCHD screening is in Puerto Rico. But with a population of about 3.5 million people, it's approximately 35,000 births a year, so not that many hospitals that are actually doing this. So hopefully this will provide SERGG another reason to hold a meeting in Puerto Rico and come and meet the place, and actually immerse yourselves in the wonderful activities that are actually taking place in the Puerto Rico Newborn Screening Program. So, closing that parentheses, let's talk. Oh God! Oh, that wasn't me. Okay, great. So. Now I understand. So, of course, tyrosinemia type 1, I'm preaching to the choir here. Everybody knows that this is a fumarate acetoacetate hydroxylase deficiency, whose reported incidence is about 1 in 100,000 birds, except for this cluster in Canada, where it's closer to 1 in 17,000 live birds. Its symptoms include, in its most acute forms, acute hepatic failure and death within 1 year of age, so it's a very serious disorder. And in its chronic form, similar presentations, but just a bit milder as those for the acute form. I have borrowed this slide from SIMD's NAMA course, which I attended back in October of 2015. So as you can see, the FAA hydroxylase results in accumulation of succinylacetone. This compound in an unaffected person is essentially very low levels in blood. Therefore, its presence in dry blood spot samples collected at birth are a strong indicator of tyrosinemia type 1. So in essence, that renders succinylacetone the ideal marker to detect tyrosinemia type 1. And one of the biggest challenges in tyrosinemia type 1 screening in the US is that when the RUSP was first established, tyrosine was identified as the marker of choice for the different tyrosinemias, which are listed here in the slide. However, as you might expect, detecting tyrosine not only would identify tyrosinemia type 1, but would also identify type 2, type 3, and transient, as well as some cases of liver disease. So it's not a very specific marker. Therefore, it would trigger a subsequent set of laboratory tests and essentially take more time to reach a definitive diagnosis. Succinylacetone and its detection really enables very specific identification of tyrosinemia type 1 patients. However, as good as that sounds, it does present challenges because it is not detectable by all newborn screening methods. So let's talk a little bit about the status of tyrosinemia type 1 screening in the US. 52 newborn screening programs claim to screen for tyrosinemia type 1, and this information was gathered from the APHL's New Steps program. Out of those 52, and of course I'm including the District of Columbia and Puerto Rico, 51 are required by law. Now, of those 52 programs, only 41 can detect or have the ability to find succinylacetone in the dry blood spot specimen. And we know that because they either participate in our quality assurance program or they self-reported this information to the New Steps program, which is housed in APHL, and the acronym stands for Newborn Screening Technical Assistance and Evaluation Program. And it's also HRSA funded, if I'm correct. Yes. So who are those that are not using SUAC in one way or another? You can see here that, of course, the majority of the US has adopted succinylacetone testing in one way or another. There are still a few scragglers out there. And we wanted to understand, well, why is this? If some people can do it, why cannot everybody else? You know, what are some of the barriers, some of the challenges for this? So this really led us to ask ourselves, is the United States really screening for tyrosinemia type 1, as we claim? So the CDC's Newborn Screening Quality Assurance Program, in partnership with Dr. Matern at the Mayo Clinic, as well as consultation with the Secretary's Advisory Committee, we led an investigation to identify some of the challenges and barriers to screen for tyrosinemia type 1 in newborn screening programs, and to see exactly why cannot we achieve complete harmonization of succinylacetone testing in the US. So this was a multi-part investigation, and I would be remiss if I didn't share with you why an SQAP is involved, and what is an SQAP. So here's my plug to my home program. The Newborn Screening Quality Assurance Program is the world's only comprehensive quality assurance provider of dry blood spot quality control and proficiency testing materials. We cover all the primary markers for all disorders in both the core and secondary panel of the RUSP. And it's a very unique program, and it serves all of the state newborn screening programs, as well as over 500 laboratories worldwide. In our offerings, we provide proficiency testing materials, quality control materials, some other reference materials for up-and-coming tests. We perform filter paper evaluations before any newborn screening blood collection device is actually marketed. It comes to CDC to ensure that it is of the highest quality and it meets all of the required standards by the FDA. We should remember that the collection card is a Class 2 medical device regulated by the FDA. So it undergoes very stringent testing. We provide training and consultation, and we also work in trying to develop methods or different approaches to enable high quality newborn screening based on blood spots. So now you know all about our program. I'm going to talk about the two aspects of the investigation that we undertook. One was very laboratory-centric, which is what I'm going to start with, and the other one was a survey that we got approved by the federal bureaucracy to actually query all of the newborn screening programs in the US. So starting with the laboratory challenges, back in the early days of succinylacetone testing, the first what I would consider high throughput testing was published in 2004 by some folks in Canada with helps from some of the folks from the New England, Massachusetts screening program. And this test was actually taking advantage of tandem mass spectrometry, which, if you think about it, tandem mass spectrometry really enabled the explosion of newborn screening disorders that are detectable in the dry blood spot. I'm a mass spec guy, so I just had to say that. So those first assays that were reported in 2004, 2006, they, through the use of chemistry, essentially derivatized the succinylacetone molecule, which is very hard to detect in its native state by mass spec, and essentially turned it into a hydrazone, or chemically derivatized it. And this chemical derivative made it very easy to detect in a dry blood spot extract. There were several iterations of this succinylacetone extraction and detection scheme, and some were very straightforward, some were not. But the point of all that is that there were no 2 or 3 laboratories using the exact same method, which, as you might expect, led to some serious variability in the kinds of numbers that were observed in the early days. Recognizing that this is an issue, a vendor came out with a kit that was approved by the FDA that included succinylacetone as one of its target markers. And that is, of course, the Neo-Base kit manufactured by PerkinElmer, which is probably the largest provider of newborn screening reagents and kits worldwide. So this kit was introduced in 2008, and it also took advantage of the hydrazine derivatization, again, chemically altering the molecule succinylacetone to make it more amenable to be analyzed by mass spectrometry. And what was really unique about this is that not only could you detect succinylacetone, but you could detect it at the same time that you detected all the amino acids and isocarnitines, which are now commonly detected by newborn screening programs worldwide. So you did not have to do a second or even a third step in the laboratory, of course, time-consuming, sometimes laborious, in order to achieve the presence or the absence of succinylacetone in your patient specimen. So this certainly was a step in the right direction to make succinylacetone testing more common in newborn screening laboratories. So those are the 2 largest classes of assays that are currently performed in newborn screening labs. So how are they doing? That's one of the key questions that our group at CDC has been examining since the year 2008, when we initiated a succinylacetone proficiency testing program. And just to give you a little bit of background on the program itself, we send out quarterly blinded specimens to all of our participants, and we essentially ask them, tell us what's wrong with this specimen, and tell us whether you consider it within normal limits, outside normal limits, and also tell us the cutoff that you use to make such a determination. So we use all that data essentially to evaluate laboratory performance at one specific point in time. And that is the beauty of proficiency testing. It really mimics the actual practice of newborn screening as closely as possible. Of course, when you get a batch of actual patient specimens, that batch does not come with a clear label that says this is for succinylacetone. So, of course, we still encounter a few challenges, but it is as close as we're going to get to assessing true laboratory performance for succinylacetone testing. As you can see here in the graph, in 2008, we started with 8 participants, and this is all domestic, by the way. Last year, we had 32 laboratory participants. Now, keep in mind, I mentioned earlier that 41 newborn screening programs have the ability to detect SUAC, but only 32 participate. We have to remember that some of the laboratories are actually regional laboratories. For example, the Oregon laboratory performs testing for New Mexico, Idaho, Hawaii, Alaska, whereas every state has its own program that is managed through the Department of Health, even though they may not have their own laboratory. So that accounts for the discrepancy in numbers that you will see in these slides. So I'm going to focus on the laboratories. We also provide quality control materials, and these are materials that laboratories test over a 6-month period, and they're really meant to transcend any change in kit lot, and it's really supposed to give you sort of a time-lapse view of your laboratory's performance in detecting succinylacetone, because the levels are the same, they don't change. So in an ideal world, your QC chart would essentially be a flat line if everything's going according to plan. Of course, that's not exactly how it goes, but that's a completely different story for another day. What I want to highlight, however, here on this slide is the great variability in the actual analytical numbers that our laboratories are producing. This is data from 2012, which is presented in the publication that summarizes this talk, which we published last year in 2014. Here I choose to highlight 3 reporting method categories. One, a non-KID tandem mass spec category, derivatized. One, non-derivatized. And of course, NeoBase, which is the FDA-approved kit available in the US. I want to draw your attention to the center line and the lot 224 data. Look at that error bar. It's gigantic. And that should, by itself, convince you of the great variability in these assays and the numbers that they provide. And what does this mean from a practical standpoint? We cannot speak to each other in the same language because we're just not equipped to do so. Different laboratory methods have different biases, and that's going to be reflected in the difference in cutoffs as well. So when laboratories start sharing cutoffs, which they invariably do, there needs to be some harmonization we need to speak the same language. And this is not necessarily a measure of bad performance. All this chart is supposed to say to us is that, wow, the methods that are out there in the newborn screening labs yield vastly different results, and we need to be mindful of that. Of course, the one method with a very small error bar is the KID method, as you would expect. The data from that method clusters very well. But, again, under lot 224, you will see that that's the method with the lowest bias. And for an enrichment of 10 micromolar of succinylacetone, you recover about 2 micromolar. So it's a very low recovery method. Again, not necessarily a bad thing, but a state that uses NeoBase for its succinylacetone testing cannot directly compare numbers. Wow, 5 minutes already. So let me move on. In the sake of time, I'm just going to once again reiterate the fact that when these laboratories compare cutoffs, you cannot do a direct comparison unless you're using the exact same method. And here you can see that for cutoffs, and this is last year's data, which we just published a couple of weeks ago, we have cutoffs from 30 laboratories, a minimum of 0.5 micromolar and a maximum of 5.4 micromolar. That in and of itself is evidence that harmonization is absolutely necessary before we can say that we are doing succinylacetone testing in the same way. So, okay, I think I've summarized the quality assurance. Let me talk to you a little bit about the survey that we did. We sent a survey which was approved by the federal bureaucracy to all of our state participants. 27 of those 37 laboratories responded. And, okay, another screen came up here. It's kind of, there we go, thank you. Only domestic programs participated in this survey, and boy, was this survey full of good information. So the very first question we asked, does your laboratory measure SUAC and dry blood spots? Out of those 27, 15 said yes, 12 said no. And based on that answer, then they got a separate specific set of questions. So for those labs that are measuring SUAC, which again was 15, the most salient data is that many times one of the biggest challenges is time and money, of course. Budgetary restrictions were not a concern for those laboratories to initiate succinylacetone testing, which we thought was very interesting. And the vast majority of those laboratories also said that technical resources were not an issue either. We pretty much knew some laboratories would do that, would answer that way. So that was no real revelation. We did want to ask a couple of open-ended questions, and here are two of those open-ended questions. What were the major challenges? We want to understand what you did and how you did it. So the most salient point of all this is that most people that started doing succinylacetone testing did it because of the availability of a kit. So a lot of newborn screening programs rely on vendor-provided technologies to effectively initiate screening for any particular disorder, or in this case, analyte for tyrosinemia. Now, for those labs not measuring SUAC, we ask us a different set of questions, and 50-50 budgetary restrictions were an issue, as well as insufficient technical resources. But we also asked them, if you're considering succinylacetone testing, would a recommendation from either the advisory committee or the Secretary of Health and Human Services herself be impetus enough for your state program to consider adopting succinylacetone testing? And boy, did we get an earful, which I've chosen not to include in here, but I will summarize in a minute. We asked them, what are your most significant challenges? Some folks were adamantly opposed to changing the methodology that we're using in the laboratory, because that, of course, would entail a completely different clinical and analytical validation. They did not have the resources, nor the staff, and in a couple of cases, not even the desire to even entertain detecting succinylacetone in their dry blood spots. The vast majority of them said money and staff, of course, are an issue, even though that in the previous question they answered half and half, and equipment and space. Now, the one thing I want to mention, there were a couple of responses that said, we really do not care if either the advisory committee or the Secretary of Health and Human Services says that we should be doing this, we're just not going to do it. And following this survey, we actually got a couple of phone calls from some people who, in a very colorful way, indicated their displeasure that this was even being considered at the federal level. So that just once again goes to show that sometimes stuff at the federal level does not necessarily communicate or impact activities at the state level, and that's certainly an area upon which we can improve. So since I have 2 minutes left, I'm going to summarize. I think there's no doubt that succinylacetone is truly the best marker to detect tyrosinemia type 1. If anything, I hope you take that back home with you. And that is independent of the analytical method. 52 programs in the nation claim to screen for tyrosinemia type 1, but are they really? I'm not going to say one way or the other. That's certainly a conclusion for you to reach. Of course, our program at CDC is ready to assist any newborn screening program that wants to initiate this kind of testing. And we presented these slides at the Secretary's Advisory Committee a couple of meetings back in 2014, and it was very, very clear that a recommendation would not be helpful, and in some cases actually hinder the adoption of succinylacetone testing by the screening program. That was really, really interesting. All that being said, after we published the data and after we discussed it at the Secretary's Advisory Committee, the Secretary herself adopted the recommendation in March of 2015 to encourage state newborn screening labs programs to adopt succinylacetone as a marker for tyrosinemia type 1. So with that, here are some of the people that were absolutely instrumental in getting these slides together. I want to acknowledge New Steps and APHL for providing some of the data. The folks at Mayo Clinic, Dr. Matern, Dr. Ronaldo, for some very good discussions. Our folks at CDC, but most importantly, all those state laboratorians and programs that share their trials and tribulations with us and that allowed us to actually share that information with you. And hopefully this will provide a window into some of the thinking that goes on in newborn screening laboratories in the US. So with that, thank you very much for your attention. Okay.
We'll get to hear a follow-up to this since I'm giving the next lecture. But just as a direct statement, several of the newborn screening labs actually can't incorporate it because they have problems figuring out how to take care of the safety issues mandated by the state for the hydrazine derivatization. So it's not that states don't want to do it. The problem is that they really do have to disrupt their laboratory processing in terms of construction of hoods and things like that, that can present barriers. And the other thing is just in terms of the number of states doing it, as you stated, it was primary or secondary tier for screening. And even, at least in my own survey of speaking with some of the states, it turns out, although they say when they answered yes to the survey, but they actually don't have it in practice yet. Mm-hmm. So it really is less than 42 states.
Right. Yes. We can only go by the data that's in front of us and by what's reported to us. So that certainly happens. And we do have an additional checkpoint, if you will, and that is we can track participation in our own program. So we know who's doing it, or at least who can do it. So, and yeah, unfortunately, 20 minutes is certainly not enough to highlight all of the nuances of this. So, yes, sir.
Very nice and informative. My name is Nicola Longo. I'm from the University of Utah. And my question is, every state obviously has cutoff. And what happens if you ask them to identify whether a child is affected based on the newborn screening report? Do they identify affected children or not? I would find this information very useful because that really would convince me of whether they can do the job or not do the job. Providing a number is very useful for harmonization, but the most important thing is really knowing yes or no.
Right. We did ask those kinds of questions as well. And many states have been trying prospectively to test their cutoffs because many of them set their cutoffs based on one particular state's repository. And some of those patients had succinylacetone levels which were fairly high. I want to say the state of Texas has identified perhaps 3 or 4 patients since they started doing this in 2009 or 10, if I remember correctly. And all of those patients have had screaming high levels of succinylacetone. But nobody can really replicate this presence because it's so rare. So that continues, I guess. As, we just need to continue identifying patients.
One quick question. In a normal individual, based on your
I think she wants you to use the...
So the question always is, in a normal individual, should you quote unquote detect any succinylacetone? Or is this just, and so is it a problem of the technique giving you a number that you have to be comfortable with calling it a real negative even though it's there? Or do you now feel that actually everybody, normal individuals, actually have some small amounts of succinylacetone?
Well, it depends on the method. We have seen endogenous levels that can go all the way up to 0.5 micromolar. Some methods, we get data back that's 0.1, 0.08, which is noise, essentially. And again, depends on the method. So once again, we need to speak the same language in this. So thank you.